There are two locations for your Bone Talk hosts. You can find Florida Orthopedic Board certified surgeons at the original Port St. Lucie location on US 1, just north of Walton Road, and at 1151 Southeast Indian Street near Willoughby in Stewart. Phone 335-4770. That's 335-4770 for appointments at either location. Doctors Powers, Sellers, Where's Becky, Forster, Williams, and Southern, providing the benefits of an academic institution with the true convenience of a private practice. There are orthopedic appointments, x-ray, and physical therapy at both locations. Port St. Lucie on US 1, just north of Walton, and in Stewart on Indian Street near Willoughby, where walk-ins are always welcome. The Surgery Center and MRI are in Port St. Lucie. Florida Orthopedic Specialists in Port St. Lucie and Stewart, 335-4770.
Oh yeah, there we are. Nice.
Much too far, right?
There's some background.
It's 10:08 at WPSL 1590, the talk of the Treasure Coast, and you are on Bone Talk from lovely Stewart, Florida, I presume, because I see that.
Yes, sir. We are here together in Stewart, Florida.
Yep.
Yeah, you can hear us all right, Greg?
A little echoey, but that's okay. So how you guys doing?
Doing great. Good day here. Different show for us. We got both of us in our Stewart office, and so we're doing it together in Stewart. It's of course our walk-in urgent care clinic. And Dr. Sellers, one of these days he'll join us from the Port St. Lucie office. He's been especially busy in surgery.
Well, yeah, and of course I've been waiting for Dr. Sellers to come back, because it was very nice of the people next door to build a Popeyes next to him so he could have his Cajun food.
Oh, yeah. Brings back to New Orleans. Yeah, he was there for like 10 years in New Orleans. LSU Orthopedics for a while.
Yeah. Oh, yeah. Well, and he also was working with elite Olympic athletes who were working out at LSU as well. So, oh, yeah. Back in the old haunts. It'll be good to have him around, but glad to have you guys here. And 340-1590 if you got any question for the doctors. What's up?
Yep, and if you want to give us a call and come and see Dr. Ed Southard or myself, Dr. Joe Where's Becky, the clinic telephone number is 772-335-4770 for Florida Orthopedic Specialists. And again, we have the two offices in Stewart and in Port St. Lucie. Dr. Southard, I had a question for you. So the resident doctor that I'm training had a question for me about shoulders and labral tear in the shoulders. And my quick answer was, forget about labral tears in the shoulders. I don't want you ever trying to diagnose those. They're rare. I tried to explain to them, that the labrum is a type of ligament that's holding that bone capsule together. But when do you see these? When are they actually a problem, I guess is my first question.
Yeah.
And am I wrong in that they're very rare as the source of pain?
That's the key there. Yeah. So as we age, the labrum tends to wear down. I know Dr. Becky's point is it's a ligamentous type structure. We've talked about the size of the sockets and various parts of the body, and one of the unique things about the shoulder, which is why we can do the things we can do with our arms that we can't do with our legs and other ball and socket joints. Is the soft tissue anchors and support structures. Labrum being one of them. Essentially, it's a bumper. So they'll use it to have children or played bumper pool or bumper bowling when you were a kid. Think of those little tubes that you put in the gutters, and that's the first line of defense against the shoulder coming out of its socket in extreme ranges of motion. And plus the capsular ligament, the structure, so on and so forth. Our labrum degenerates as we get older. So once you start looking at about 30, 35 years old, there is some early degeneration of the labrum simply because of the amount of stress that it sees throughout its entire life lived.
And we could see that on an MRI. Some radiologists will say partial tearing of the labrum or degenerative tearing of the labrum. And that's just, it's more or less arthritis in the shoulder, not a true tear of the ligamentous bumper.
Right? To a degree. So a true symptomatic labral tear is one of instability and apprehension, and there's a true separation between the actual soft tissue structure and the bone that it's adherent to. The posterior tear that you see in symptomatic athletes, baseball pitchers, so on and so forth. When you see slap tears in patients that are in their 30s, 40s, and 50s and so forth, our literature has gone back and forth, but we're starting to really understand and appreciate that a slap tear in a 50-year-old is just a degenerative labral tear in a different part. Yeah. So to a degree. I mean, for simplistic terms, yes. It's but if you don't have a true instability moment, if you don't have a true problem with issues with the shoulder feeling it's going to come out of socket, so on and so forth, most of these don't need to be addressed. Now, if posterior labral tear, that's another one. For example, patients that are bench pressers or athletes that do a lot of pushing mechanism feel like their shoulder wants to come out of that as it goes, the force goes anterior to posterior or front to back. Those tend to be addressed. For patients that have instability moments where the shoulder wants to come out the front and the anterior labral tear, those tend to be symptomatic. The key one is the bony Bankart or the soft tissue Bankart in the dislocator of the shoulder, where it's an anterior inferior separation of either labrum or the labrum with a small piece of bone. Those are symptomatic, and those you can see on a clinical exam, and patients will give you a pretty characteristic history. Oh, I don't feel comfortable with my arm in that position. I feel like it wants to come out. Or when I put pressure on my arm and it feels like it wants to come out the back. They're pretty telltale stories. Most people don't say when I put my arm over my head, it wants to come out the top. They just feel an uncomfortable shift secondary to the, that ligamentous structure no longer being what it was when they were, say, in their 20s.
So when you think about all the different causes of shoulder pain, is it a pretty, in people who have the majority of their pain from a labral tear, the majority of their, not something else, is it a small amount of people that have the majority of their pain from the majority of their shoulder pain from a labral tear, would you say?
I would say, usually, I mean, it's your younger athletic patient are the ones that you're more likely to find a true symptomatic labral tear where that's the only source of their problem.
And when you say younger, less than 30, less
than
30?
less than 30 usually.
Okay.
Your 30-year-old, 20-year-old, like I said, especially your overhead athletes or athletes that do a lot of push-pull. Mm-hmm. It's like anything else. And for me, that's one of the most rewarding surgeries is you stick a scope in a young patient or younger patient, and their shoulder's pristine, their rotator cuff muscle is pristine. The joint itself is beautiful, but then of course there's a little labral tear there. I mean, if you put an anchor or two in those or more, depending if you need. I did a posterior labral repair on a patient not that long ago whose shoulder was perfectly healthy inside. He just had big, huge separation on the back side of his labrum. We had to put 3 anchors in there to put it back into place. Those are really nice surgeries because the patients do really well when the surgery is indicated for the right reason. Patients that don't do well are the ones that get labral repairs or slap repairs. They get their shoulder over tightened because you have to bring a little bit of that capsular ligamentous tissue along with the labrum so you get a nice secure bumper. And then those patients have tightness, they have mobility restriction, some of them go on to early arthritis. So that's where we're starting to think differently about what is a labral repair, in particular, what is a slap tear in the shoulder, and should we even treat it?
Now, so again, are you talking 30 and 40-year-olds with that type of surgery?
Yes, the limitations as you get older tend to change. In my practice, for example, if I have a truly symptomatic slap tear in a patient that is north of 30, I'll do a biceps tenodesis on that patient, which, one of the things that a lot of people don't recognize because they're not surgeons is the bicep tendon comes up over the arm and inserts onto the top of the labrum. That is what the superior labral anterior posterior tear is. So the actual long head of the biceps anchors into the top of the glenoid and it's attached to the superior labrum. That chronic tension of bicep pulling on that soft tissue makes it near impossible for it to heal properly if you're constantly irritating it. I mean, think of it as your little brother that's constantly flicking you in the ear, just, flick, 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 flick. I mean, that's, an equivalent of that. Cut the tension generator off. You can rough up the glenoid to allow for bony growth, new stem cells to adhere. Because when we do rotator cuff, soft tissue repairs, we always want to rough up the bone and create a rough surface so there's some bleeding, so you can promote healing and adherence of the soft tissue to the bone. So that's one of the ways to deal with a slap tear in an older non-athletic patient, is to rough up the surface, clean out the frayed and the loose labral tissue, provided it's not subluxing down into the joint, cut the bicep tendon, allow it to scar down and heal on its own, and it quite often, if not more often than not, will heal appropriately if you're no longer pulling on it and allowing it to come down.
So when you're talking about roughing it up, I'm thinking in the knee, I hear about it a lot with microfracture, which is where kind of the bone, they're roughing it up in order to stimulate inflammation and the body to come and send some extra resources to help heal it up. Is that the same thing you're talking about in the shoulder when you say rough it up?
To a degree. A microfracture is a little different because you're digging down into deeper layers of the subchondral bone to promote stem cells to come up to get that fibrocartilaginous layer. It's a pseudo cartilage, so to speak, to try to reform over this. And with a shoulder repair, whether it be rotator cuff, labral, or so forth, you really just want to get down to bleeding bone, not really deep into subchondral bone. And that being said, you're not even getting into subchondral bone because you're up and around the back side of the articular surface of the glenoid. You just want to promote blood because blood brings nutrients to tissue and promotes healing.
So you mentioned before putting an anchor in it. And so the difference between doing a repair and putting an anchor in, and then I'm guessing sometimes you just clean it out and don't necessarily repair or put an anchor in. Am I understand? Are those different things?
Well, anchor is just is a instrument that we use in the repair. So it's something that we use. We treat, specialized suture.
Does it look like a pin or?
It looks like a little peg.
Okay.
And there's different kinds of it. There's metal anchors, there's peak anchors, there's bioresorbable anchors. There's now knotless anchors from certain companies where it's actually just a wad of that same suture that expands when you put it in, which is a really nice technology because there's a little bit less that you're putting into the body, less worry about resorption, less worry about the body's response to a foreign body, so to speak. And it makes it, and a lot of with the knotless anchors now, it also changes what we call the knot profile of the suture. So if you have something that's implanted into a plastic, for whatever lack of a better term, anchor, and then you try to tie a knot around it, it's usually a loop type stitch. There's a lot of stitch in there. The knot can fall into the articular surface to become an irritant. Whereas with these new knotless anchors, you don't need a knot. The suture is all part of one, and it's a cinch technique where you capture your tissue, you prepare your surface by getting to that bleeding surface. You make a little pilot hole in the bone, and you sink the anchor down and cinch it down into place, and that gives you your repair. So your repair, you have to augment your repair with something. If you're not putting something in, you're not repairing it. Where I was saying before with the bicep tenodesis, where you cut the bicep, you don't really repair the labrum, but then people will go ahead and then anchor the new cut bicep somewhere else in the body. Some will do it inside the joint with an anchor. Some people will do it in the front of the bone, and some people will go under, down lower on the humerus underneath the pectoralis muscle and do what's called subpec tenodesis. That's the one I actually prefer, and do it that way.
So is this like an open shoulder surgery, or is this a scope?
If you do a subpec tenodesis, it's a combination of two. It starts off with a scope. You take care of what you need to take care of inside the joint. and then there's a small incision in the little axillary recess of the, well, it's actually not axillary recess, is inside the shoulder, right in the axilla, underneath, just in front of the armpit, so to speak. Other people will do the tenodesis in the shoulder at the same time of the surgery, but they do it outside of the joint, if that makes sense to you. So you're still doing it with the scope, but you're not in the joint. You're in the subacromial space in front of the shoulder, so to speak. Still under the skin, still under the deltoid muscle, but outside of the rotator cuff musculature.
So then how long is recovery on something like this?
If you're doing a labral repair, a couple of months, depending on the athlete. There's some athletes, for example, with posterior labral repairs or anterior labral, we're looking at 6 to 9 months before they can do their contact sports. For contact sports, we're talking about athletes that are hockey players, football players, so forth. Your average person that just has a labral repair, they're usually back anywhere from 3 to 6 months, depending on how much repair you have to do. The tenodesis is usually scarred down, and the holes that you drill into are usually filled in about 3 months. It all depends on what you do, and that's the argument for different techniques. Some people do a tenodesis where they just put a staple or an anchor into the bone on the outside, and they're looking more for soft tissue adherence, whereas other people, myself, that I do a sub-pec tenodesis where I go underneath the pec muscle, I take the bicep tendon and I send it through the front and back side of the humerus. You want that to scar down, you want the bone to heal and around it. Now the implants that we use are very strong. They're not likely to pull out, but you also want to protect the soft tissue because you're trying to anchor things back down again. If you're doing these repairs, you're doing them on functional athletic people that want to get back to somewhat of norm. So if you push them to go back too soon, they'll have a failure of their repair.
So you mentioned athletes and shoulder injuries, and so my friend is a big hockey fan, and he was trying to tell me how tough these hockey players are. And I'm not bashing hockey players. Hockey players are the toughest out of all the athletes. Maybe rugby is tougher, but hockey is some of the toughest athletes. And so he was telling me his argument here was after the season, hey, look at this list of injuries that the team reported that shows how tough they are. And it says one has a separated shoulder he was playing with, one has a rotator cuff tear he was playing with, one has a labral tear that he's playing with. And I'm telling him, yeah, your hockey players are tough, but that doesn't tell me anything. Right? A separated shoulder could be a mild little shoulder sprain that is technically a shoulder separation. Rotator cuff tear, we all have rotator cuff tears. It doesn't make you tough to play with a rotator cuff tear automatically. It may be, but these vague diagnoses may sound serious, but it may not be. Yeah.
That's interesting. So yeah, that's a tough sport. Anytime you could be standing in front of a plexiglass wood device and all of a sudden someone comes at you full tilt and slams into you. Me as a former lacrosse player, when somebody touches your back, you're jumping up and down screaming, push from behind. I feel like that's all I see in hockey is push from behind. And then of course there's a face plant into the boards followed by a fist fight. So hockey's a great game. So
yeah. I mean, the hockey puck to the arm has got to hurt worse than your average lacrosse ball to the arm. Or
I would think so. Yeah, no. Although I think their pads, the hockey players are pretty well padded. Yeah. My understanding is the guys that block the shots, there's that little area, in front of, there's some of the base former catchers, hockey knee pads are very similar to those. They have a nice big protection in the knee, and then there's a little gap just below the knee where essentially your tibial plateau is, and then the shin guard is so they can bend and flex and move. And that little area where it's unprotected is where they catch a puck all the time, blocking a shot, and that's painful. I mean, getting hit full tilt with a hockey puck, that hurts.
Yeah.
Yeah, I'll never forget when we had the San Diego Mariners were created when they created the World Hockey League. And so we had this one great player. He played in the NHL for a long time, Andre Lacroix. And so I was going to get this real artistic shot and right behind the net. And so, I'm lying on the ice and, and all of a sudden these, I hear, of course, I didn't even see it, this puck goes sailing by my head. And as it turned out, one of the other guys is a practical joker on the team, and he cut a hole in the net. And so I got this great shot before it shattered the lens of my camera of this puck coming right at me. It was marvelous. I of course got chewed out because I ruined the camera, but outside of that, it was a neat shot.
Who would you guess most force generated, by a ball in sports? Is it going to be a baseball or is it going to be a hockey puck? Which one's going to do the most damage? At maximum.
It's tough. It's tough. The whole idea, physics formula, force equals mass times velocity. So what moves the fastest of all those things? Probably a hockey puck at full speed. I never clocked it, but I can only imagine. But then again, it's the mass of a hockey puck is a lot smaller. I would almost err on the side of, even the soccer balls are moving at full tilt. If you think about it, how does a person playing soccer get a concussion getting hit with a soccer ball? It doesn't make any sense, right? But they do.
Yeah.
Well, if they're going like 60 or 70 miles an hour or more. Yeah. And did you happen to see the video of the umpire the other night? I forget who the pitcher was, but he was throwing 100 miles an hour. And somehow, some way, the catcher missed the ball and it hit the umpire on the side of the neck. He went down like he was shot and did not come back in the game. It was like, whoa, I'd never seen anything like that. I've seen foul balls come back up.
Yeah, but think about the velocity of a golf ball coming off a tee. I can only imagine the speed. Now, a golf ball is very, very small. If you're 200 yards down range and you get hit in the back, it stings, but it doesn't hurt. But if you get a bad shank shot and you're within probably 20 yards of that ball and you get hit with the recoil of it coming off of the club, and that thing's got to be coming off, in the range of like 200 miles an hour. I'm probably exaggerating, but I think Dr. Worzbecki is.
Yeah, I'm on it right there. Yeah, 82 meters per second, whatever that is.
Wow. So and a friend of ours who's at ESPN, Sage Steele, was hit. I forget the golf tournament. I think it was a PGA where she was standing very close to the tee box, and there was an errant tee shot, and she had broken nose and teeth and you name it. It was tough. Yeah.
Yeah, interesting. You're right. Hockey puck over a baseball. When you compare their average fastest velocity and you consider their mass and force, it's going to be the hockey puck is going to do going to create the most force. Yeah, and it's interesting. We talk about it sometimes in sports medicine with a condition called commotio cordis, which is where something like a hockey puck or a baseball will hit a player in the chest. And if a player gets hit in the chest at the exact wrong time in the heart's cycle of beating, it can make the heart go into a very fatal arrhythmia. Greg, you may have seen it's kind of some wild YouTube clips of some unfortunate accidents when it happens. And it can look like just a minor thing, a player taking a baseball to part of the chest, even like a little leaguer. It's not even going that fast. Or like something like a judo match and someone will take like a karate chop or a slight punch to the chest. They'll move around. Maybe the baseball player will take, it will take a few steps towards the first base line, look completely fine. Or after this, like the judo match, it'll be 5 seconds, 10 seconds before the player just collapses. And you say, wait a minute, what happened? That came out of nowhere. It's because that force put the heart into an atypical arrhythmia, and it takes a few seconds for the whole body to kind of respond to that, and then they go down. And if they're not properly resuscitated with with the pads and the shock and cardioverting, then they can die. It's very serious. That's why they now sometimes wear these pads. In fact, lacrosse players, they have some specialized ones that cover the heart.
They're this whole idea of this arrhythmia is the reason why schools are now requiring AEDs, there's automatic defibrillators where you don't really have to have much training. They're self-explanatory. You put the pads on by the pictures, the computer recognizes the rhythm, will charge the shock. Now someone has to be there to push the button, but they're, basically yelling
in a timely manner.
That's why they're on the sideline. Actually, I had a friend of mine who was a year behind me in high school. He died years ago. I graduated high school in the 90s. He was in his first or second year. I forget what year it was, up at UMass. Got hit in the chest with a lacrosse ball, died on the field. same thing. It's happened more than, it's more common than you think. I think, didn't we have it here in St. Lucie a while ago?
I don't think we had a true case of the commotio cordis, but they had a cardiovascular event. Jessica Clinton, who had the mitral valve
Sure,
prolapse.
and you've been involved in that for years. Her family has funded several AEDs.
Yep. Yeah. So her condition, I think, was an undiagnosed mitral valve prolapse where the valve wasn't doing its job properly. And it led to this thickening of a part of the heart that shouldn't have been thick, that led to an abnormal electrical signal. And then she went down as a cheerleader when a sporting event was going on. So different than the thing we're talking about.
She had Holcomb or something, or hypertrophic cardiomyopathy, or
but her valve was so leaky
Yeah.
that I think it led to an atrial hypertrophy that led to that led to something else.
But this is, it's very uncommon, but it's a real thing, to Dr. Wierzbicki's point. And I don't know the research behind it because I haven't paid that much attention to it, but yeah, the governing body that oversees the safety of padding in lacrosse, they've now required that all field players wear some type of breastplate across the chest.
And that's in all levels of lacrosse? Or
I don't know the answer to that.
collegiate though? They do?
Oh, collegiate definitely, varsity definitely, high school varsity. I don't know if they're doing it at the youth level. I would assume they are. And it's just now you basically have a stormtrooper shell over the top of your chest. The players hate it because we all hate changes. I played with some little pads that were just, they were actually under pads. They were designed to give extra cushioning to the shoulder pads because the technology of the shoulder pads weren't there, and a lot of us just started wearing those only. So it's changed quite a bit, but it's all in the nature of safety. I remember when I was growing up, and Greg will too. Ice hockey players didn't wear helmets. Then they wore helmets. Then they wore helmets with visors. You know what I mean? It's changed, for years and years and years. Look at the other football helmets. You had a leather thing, and then there's a leather thing with a cage, and then the cages get bigger. Girls lacrosse was wearing nothing. Then now they're starting to all wear goggles. So it does change. Greg's position, baseball. When did people start wearing the ear cups and then the elbow padding? And
that's not that long ago. You figure, of course, when we were playing, which the dinosaurs are still roaming the earth, but we didn't have any helmets, and to the best of my knowledge, I can't even remember when they came in. Maybe the 80s, I think. Some of the players got seriously hurt, and then one of our catchers, Steve Yeager, of the Dodgers, invented that catcher's flap over his neck because of an injury he had when a part of a bat stuck in his neck. It was scary, and luckily 3 of our orthopedic guys from Centinela Hospital were there, and they saved his life. And of course, he came up with that invention right after that. So yeah, you're right. The safety equipment, 80s, 90s is when the development really started and all that stuff.
I can't even imagine what it was like back then. So the catcher, they had the simple chest thing, and they probably had the catcher's mask, but really nothing else. Did the umpires even have anything back then? Were they just wearing a simple chest pad? I can't even imagine them being in that line of duty and without any kind of equipment. I can't imagine it.
The American League guys wore their chest protectors out of the uniform, and they were like mattresses almost. The National League guys wore kind of a glorified flak vest. Now everybody is under the uniform. So it's all standardized now, but it's all like what you guys were talking about years ago, where the quarterbacks are, wearing flak vests all the time. I think so are the umpires as well.
Yeah, and that also brings up a topic that we talked about a few months ago. I think it was a caller asked us about some of the changes that were coming with the NFL, or maybe it was you, Greg, who brought it up. The NFL is changing the helmets again, but now for the better, and it's really position-specific helmets that they're going to help to minimize injuries that are more specific to those positions. So the punter doesn't need the same kind of helmet that a running back does or an offensive lineman. And I looked into it, and I even talked to some of my buddies who are sports medicine doctors for NFL teams. And there is very little information that's being shared with medical professionals or the public about what went into this decision. Because I'd be very curious about what's the difference between an offensive lineman's helmet versus a punter versus a quarterback, and what information they used in order to generate these different helmets and what the different helmets look like. But I think it's this upcoming season that they're allowed to use these new specialized helmets. But yet it's weird that there's no information known about it.
Well, that's all what CTE generated. I mean, when you've got, a lot of the ex-NFL players that, had major
And I guess
problems.
when you're talking about something that's a potential lawsuit, the CTE stuff is still ongoing. Maybe they don't want everyone to know the exact facts of what's going into some of their decisions in order to prevent CTE, if at all possible. I guess that kind of makes sense.
Yeah. I mean, I have to dig. One of my co-residents years ago, well, not that long ago, guy behind me, he was working with one of our pathologists. They were doing a helmet study where they were going to high school with various sensors in the helmets to look at the force of contact, where's the most force generated. I would be pretty surprised if the NFL didn't do something very similar. Looking at sensors inside helmets. Where does a lineman need more protection than, say, like I said, a punter? You know what I mean? If you think about it, it's for those of us that have seen high-level athletes at that, in those positions, the front of their helmets look like crap. I mean, they're linemen, offensive, defensive linemen. They bang heads every single time. The quarterback, says Omaha. So it's it's just the way it is. You gotta love Peyton Manning, right? So how to give crude. So it's just, as soon as the ball is snapped, their helmets collide. The wide receiver, okay, maybe he has a grazing glance on his way by somebody, but usually not. But it's just, then like you said, the punter, and it just changes. The amount of contact, the amount of force. Again, we talked about mass times velocity. You get 350-pound guys going right at each other, full acceleration, head to head. And that's where the linebackers started wearing those horse collars, where they would wear those big pads behind their neck to prevent the whiplash injuries, and so on and so forth. It's like crashing into a Mack truck. How many snaps do you see a day in football?
And what you don't see as much anymore, Greg, is those caps on top of the helmets. You remember back in the day, I want to say it was like Don Beebe or one of those Buffalo Bills really made it famous. He had a concussion, and one of the ways that he was going to play through it was he put that diaper on top of it that looked like another helmet. Do you remember that?
Yeah, that was yeah, I do remember that.
You don't see that anymore. I don't know why. Maybe the helmets are supposedly good enough, or they're just that strict with the concussion and CTE policy.
Hard to say.
Yeah.
I know they've become very strict with concussions. I mean, there's regulations at high school level insofar as concussions. I mean, you have to have a baseline test. You're in theory supposed to have a baseline test. FHSA is pretty strict about this. And then you have to have, you pass your sideline test. If you don't pass your sideline test, your return to play test. There are other battery of tests that you need to pass before you can go back on the field. It's become a big deal, and for good reason. And again, when it's not just the football players, I mean, it's we talked about before. Even soccer players actually probably have as many concussions, if not more, than football players, because they're unprotected. It's the same force, and they're using their heads as instruments of play, so to speak.
Yeah.
I mean, you catch somebody's forehead, in your face, that you're going down. And in worst case scenario, you get to the back of their head in your face. That's even more. As they're trying to go for the header. I mean, they're legit real injuries.
Oh yeah, yep. Knees to the head. Yep. Feet that are accidentally striking the head. Yeah, it happens. They're vicious.
Well, and the soccer groups have all gotten together too. There was talk a couple of years back of trying to outlaw the header as a regular play because of the concussion protocol.
Yeah. There's some evidence just showing the amount of force, like you were saying, that's generated with a header. It's a significant amount, and so it's kind of the same thing with the baseball pitchers and why you can't get them to wear a helmet when they pitch. It's just such a part of the game that it's tough to take away despite all the safety concerns. I don't know. I don't know where the line is.
Yeah, no, I thought just went in my point is it's overregulation. I mean, could you imagine the game of soccer or, for those uninitiated proper football with no header?
I can't imagine.
It would be almost unwatchable. That's just part
It's
of the
one
game.
of the best parts of soccer. Well, outside of the shootout, but the corner kick and the headers for the goals.
Yeah.
It's part of the game.
I mean, name another sport out there where you're using just about every part of your body to control a ball. Yeah. I can't think of one.
No. Well, where you can't use your hands. I mean, that's why I think, of course, I've never been into that sport, but when you look at these people, male or female, makes no difference. They're amazing athletes, what they can do with a ball, with just their feet and their head, obviously.
Volleyball, you can use any part of your body, although they're not using it near as much as a soccer player.
No, they can't kick.
You can kick a volleyball.
You can't kick it. If it bounces off of your foot, it's okay. But if you intentionally move your leg to try to kick the ball, that's a foul. So for example, if you get spiked and it bounces off your leg, that's legal. But if you move your knee to stop the ball from bypassing, that's considered a kickball, and that makes it illegal. That's just interesting. But you can use any part of your arm, which is whatever. And then I don't know if you can, Greg, you might know this. I don't know. Can you use your chest or other things? Again, is it the same thing? Or does it have to be arms? I think so. Hands?
Yeah, we'll have to bring the volleyball coach up from Myers. What's that?
Does Iris have a volleyball team?
Yeah, and actually I think that we've just recruited 4 or 5 young ladies from European countries. So yeah, this is going to be a good club this year.
Men and women's indoor? Is that
just women?
Or is there
just women?
Just women,
and it is indoor. Although there is SCF over in Bradenton does have a beach volleyball team, and there are rumors that Eastern Florida and maybe IRSC will follow with beach volleyball. There we go. I'll need to cover that one. That would be fun.
Yeah. Bone Talk 340-1590. If anyone wants to give us a call live on air, and of course you want to see me or my partner, Dr. Ed Southard, give us a call, 772-335-4770 for Florida orthopedic specialists.
And that is one number for both locations too. And that's really important. So folks don't have to remember a million numbers.
Hey, Dr. Southard, when someone has osteoporosis, osteopenia, and you have to go inside their shoulder surgically, whether it's to repair a fracture or do a replacement, do you have to approach it different considering how solid their bone is? Do you sometimes have to modify certain surgeries depending on that?
A lot of that comes into play with how we manage, in particular, proximal humerus fractures. It's younger, healthier patient, and it's an injury that the pendulum has gone back and forth, and I'm sure it'll go back again at some point. At one point, in history, we weren't doing anything with proximal humerus fractures, then everybody was getting surgery, plate and screws. Then replacement came on scene, whether that be partial replacement, hemiarthroplasty versus now reverse shoulder replacement. The current thinking for the most part is if you have a multi-part fracture, which is the kind you tend to see in your osteopenic, osteoporotic patients, where the proximal humerus is broken into 2, 3, and 4 parts, and it's an older patient, those patients usually get a reverse total shoulder replacement, simply because the quality of the bone is less reliable, it's unlikely to heal, so on and so forth.
In which type of surgery is it more likely to have problems if the bone isn't solid? The standard
plate and screws.
If
you have an older patient, 70 and over, that has
that has a fracture,
that has a fractured proximal humerus, the upper portion of the arm, it's multi-part.
Okay.
Whereas you could have a multi-part. I mean, there are surgeons out there doing 3 and 4 part fractures in younger patients with plate and screws because the quality of the bone is such that the current thinking is that keeping a native bone is better than replacing it with an arthroplasty. So if you have a patient that doesn't have obvious looks like they're going to have less likely to have compromise of the bone, there's different structural anatomic marks you're looking for insofar as how much bone is broken on the inside of the bone. That has something to do with the blood supply. There's a famous study that was done by a gentleman named Hurdle, looking at how much bone is there, how much affected is possible the blood supply to the proximal humerus. The other argument is people make, the reason why we do replacements for fractures as opposed to fixing them is blood supply. You're worried about avascular necrosis. One of the reasons we do hip replacements for certain type of neck fractures, femoral neck fractures, as opposed to fixing them with screws or a plate or leaving it inoperatively. AVN necrosis in the shoulder tends to be more tolerated than, say, in the hip. So some surgeons are more aggressive with plate and screws because the theory behind that is that patients should do well if we can get the bone to heal. Older patients that is less likely to heal, bone is soft, they do better with a replacement because you're not relying on poor tissue quality. If they go on to necrosis, for lack of a better term, who cares? Because there's nothing left to necrose. You've discarded, the humeral head, and you've gotten rid of the areas that would potentially suffer from lack of blood supply, and you put a replacement in there. We use the reverse because it's more structurally sound. Patients that are older than that, when they have more multi-part fractures, they also have, in theory, a rotator cuff tear because you have the pieces that the rotator cuff is attached to are affected and pulling off. So if you have a tuberosity failure where the supraspinatus tendon inserts with a reverse, that it's not the outcome you're looking for, but the patient still has a fairly reliable function of the arm because they're not relying on the rotator cuff, they're relying on the deltoid muscle, which is the advantage. So osteoporotic, osteopenic fractures in a functional adult get a reverse of the proximal humerus. Non-functional, sick patients that it's their non-dominant arm, a lot of different comorbidities. Some of them we'll just leave alone, and if we can get enough of a fibrous union or at least some loose approximation of the bone, they have some mobility in their shoulder. That a lot of them that's all they need. I have a patient right now that I see who, a very nice person, had a dislocation of the shoulder, has some balance issues, fell, dislocated, damaged their axillary nerve, which is not common, but it is a complication of a dislocation in the older patient, and her deltoid muscle is non-functional. Only her posterior deltoid works. The anterior and lateral aspect of the deltoid are damaged from axillary nerve. I can't put a reverse in her because she has no arm function. She was doing okay. She had a little surgical neck fracture, then she fell and wound up again. Now has a 4-part fracture that, you look at the x-rays and you cringe because the x-ray looks horrible. The only thing to do for her is leave it alone. We've talked about a palliative hemiarthroplasty, just putting a big, huge proximal humerus in her just for pain control. She's likely to get little to no function. I hesitate to do that because her balance is so unsteady. If she falls and breaks around the humeral shaft, now I have another problem on my hand. She's not a candidate for reverse until I know that her axillary nerve is going to recover, which it likely won't. It's been over a year. So the only other palliative option that we discussed is doing a partial reverse. And that's a really unique thing that's out there in the literature. The ball and the socket in a reverse total shoulder are different. So your normal shoulder, your socket's flat, your humeral head is the ball. In a reverse, the ball goes on the socket side, the socket goes on the arm side. In this reverse hemi, you put the ball in as the socket, but you don't fix the humerus. You let the humerus sit there, and then the bone just rotates around it and tries to give them some stability. That's something that we may entertain, but we'll see.
And well, Dr. Joe, what happens? I mean, can the broken bone, can the broken bones, heal back for her? I mean, is that possible? No.
She's healed. No, I mean, this person is healed as she's going to get. It's just healed in a position that's not anatomically sound. It's the ball socket relationship. The glenoid is jamming into her humeral bone. Like I said, the X-ray is non-appealing. But it's one of these things where, and I'm still learning as a surgeon, as I'm still in my infancy as being an attending, so to speak. You really have to look at getting advice from other people, looking at what they would do in these situations. What are the godfathers, so to speak. Less is more. This patient and I and their family, if I make an incision on her and she gets infected, has a complication on the table. I mean, let's just say, hypothetically speaking, a patient has an anesthesia complication and dies on the table for a surgery that's less likely to help her. What's the point in doing an operation on that? And that's something people need to consider as surgeons. It's very rare, right? I mean, I don't want to be the Dr. Doom. But if your indications, and we talk about this all the time, your indications for surgery are not guaranteed to make the patient better. And there is no guarantees in life, right? There's two guarantees in medicine. There's the front end and there's the back end. Everybody's born and everybody's the opposite of that, not born. Everything in between is an odds ratio. So if I know that there's a 90% chance that I'm going to make you better with an operation, that makes a lot of sense to me to do an operation on you. If there's a 10% chance I'm going to make you better, that's really not a good odds. That right. Makes me think, I probably don't want to do this to that patient. So right. you need to be able to, in this patient situation, demonstrate that they're absolutely miserable. They've tried everything. We know what the physiological limitations are based on the injury status. What are we going to do about this? How are we going to manage that? And then you go in with, that's the whole idea of informed consent. You have these conversations with people. It's when you do surgery on people with unclear expectations or unrealistic expectations. The outcome is very similar to what you anticipated, but it's nowhere near the outcome that the patient anticipated because they had surgery with the expectation they're going to be better.
Well, I'll never forget, it was several years ago. Dr. Sellards took a call from a lady that I forget whether it was a knee or whether it was a hip, and she'd had 3 unsuccessful surgeries and wanted to come to him to fix it. And he said, "You've had 3 too many surgeries." and I don't think I can fix it. So, it was like, okay, that where he just basically told her, "I'm sorry, but I can't do anything." And you're right. You've got to have those conversations with people, and they're difficult.
No, they're very hard conversations. I mean, when patients come to you for help or advice or whatever the case may be, it's a very different conversation than you going your financial guy saying, I want to buy a 40-foot boat, and they look at you and they say, "Yeah, maybe you got to try a 20-foot boat," or "Yeah, maybe you're more of a jet ski kind of guy. Maybe you're of a paddleboard kind of guy." You know what I mean? Those are conversations where you can just deal with it. When patients come up to you and say, "Hey doc, I need your help. I can't do this, I can't do that. My quality of life is horrible. I can't do the things that I used to be able to do. What can you do to help me?" Those aren't extrinsic rewards. Those are intrinsic quality of life rewards, and you want to try to be able to help people. And sometimes it's not the easiest conversation to have, but it's the necessary conversation to tell them, "Sorry, I think that those days for you are over." And fortunately, we don't have it very often, but it does happen.
Well, and and we get back to the fact of us taking care of ourselves, where the body mass index comes into play for successful surgeries and all the other stuff. Smoking, again, difficult questions when you're dealing with somebody who wants to get fixed.
Oh yeah. No, I dealt with this up in New York all the time. I think we talked about this. I mean, I have a strict cutoff for body mass index. How do you tell a hip arthritis patient that is basically wheelchair bound, they have to exercise and lose weight before you can do surgery on them?
Right,
right.
I mean?
So I've seen it less since we've been down here in Florida. I think that's also selection bias because, a lot of the people that come to Florida, especially the non-natives, are your more active and mobile adults. Most people don't move to Florida so they can sit in a wheelchair. They come to Florida to, be part of Florida. They do the pickleball, they do the this, they do the that, they do the golf, whatever the case may be. But yeah, no, you tell a patient got a BMI of 50 who lives in New York, the only thing that they can reliably do comfortably is say like aqua therapy or water aerobics. They're a low income patient. There's 5 pools in the 5 boroughs that they can go to for relatively low cost. I think at this city of New York, I might be misquoting. There's probably somebody out there that knows better, but there's 5 or 6 pools in the city of New York where you can get a year membership for $75. You can go in the pool, you can do your aqua therapy, you can monitor your diet, you can get your BMI down. It's low impact, you don't hurt yourself, but you have to take a 3-hour subway ride each direction to get there. Who's going to do that?
Right. Right. Yeah. That's not realistic at all. Yeah.
Exactly.
Well, yeah. And of course, you tell somebody that down here, and of course, there's a pool, it seems like on every corner. So that
You can find whatever you want. And you know what? If the pool's not working out for you, there's a big ass thing out there called the ocean. Yeah.
Yeah.
You go in that body of water. If you don't like waves, you go in the intercoastal. I mean, there's water everywhere. I mean, I wouldn't recommend the lakes and the ponds. You might find yourself not needing a total hip. You might need something else like an amputation with what's growing and living in there. But we really have it pretty good down here. We have access to a lot of the things. I send my patients on beach walks all the time, low impact, low resistance. You know what I mean? Your knee hurts, you want to walk, go to the beach. Barefoot beach walks. Now, obviously, emphasize them go in the morning or in the afternoon, preferably in the morning before the sand gets hot. But it's just, we have luxuries down here that other areas of the country don't have. So.
Yeah, and it's just a luxury of being able to swim. We swam 3 days in a row, I guess, over the long weekend, and it's amazing what it does for the knees. I mean, even if you don't have problems, it's wonderful.
Yeah, if you want low impact exercise, get in the water. I mean, 100%.
Yep, got that right. Well, doctor, where do we find you guys at Florida Orthopedic Specialists?
Well, we have our office in Stewart, in Port St. Lucie, corner of Willoughby and Indian Street in Stewart, and the corner of just north of Vets Highway and US 1 in Port St. Lucie. Same number to reach both offices, 335-4770. See myself, Dr. Worsbeck, one of the other partners. Multi-specialty group, and of course we have walk-ins at both locations. Come on down and answer your questions for you.
All right, Dr. Ed, Dr. Joe, thank you very much, and you guys have a good week. Okay.
You too, Greg. Have a good one. Thanks so much.
Bone Talk right here on WPSL Port St. Lucie. Talk of the Treasure Coast webcaster to the world on TuneIn. Welcome to all the 49 countries listening to us. Wow, impressive.
This is CBS News on the Hour, presented by Indeed.com.
I'm Deborah Rodriguez. We have 2 breaking stories from overseas this morning. Britain's leader has announced he's stepping down, but first,